continued education of nurse practitioners. Okay, we just started recording, and physician associates.
Sorry.
We all know that we are essential members of the healthcare system, but it's also integral that we stay up to date with evidence-based medicine and practice and refine our skills to be the glue within this collaborative approach to medicine. My name is Rachel Irabor, and I'm one of the founding members of the Nurse Practitioner and Physician Associate resource group on Facebook and Med Lectures Express on YouTube. I am a emergency department physician associate with additional experience in the urgent care medicine, and that's as well as active in physician associate student education at a nearby university. Miss Nena Otoluka is also a founding member. She's a family nurse practitioner and acute care nurse practitioner with experience in hospital and internal medicine. The lecture will be conducted by founding member, Miss Adora Ojaid. She's a family nurse practitioner and an acute care nurse practitioner student with experience in primary care and addiction medicine. Also, our distinguished guest, who will be following along with the lecture and providing his expert opinion, is board certified cardiologist, Dr. Michael Zima. Dr. Zima is a highly trained and experienced cardiologist and is the author of the book, Modern Healthcare Delivery Deliverance, or Debacle, A Glimpse from the Inside Out. This wonderful book gives an insight into our healthcare system and addresses issues and concepts with its delivery. It's something most definitely you all should check out, especially post-COVID. This book has been held by the bookauthority.com as one of the top 12 print books and top 8 digital books on healthcare for 2022. So please keep in mind, this is an interactive forum that will last about 45 minutes and will be recorded. Please wait for the moderator to pose questions before commenting. And when asking questions, please address Ms. Ojaid or Dr. Zima, and we welcome you.
Thank you, Rachel. Thank you so much. Thank you, everyone, for coming. We truly, truly appreciate you. Thank you, Dr. Zima. To begin, the format of the lecture is going to be a Q&A. So basically, I'm going to pose a question and give everyone time to answer and then give my feedback. So I really, personally, I really want this to be enjoyable and interactive for you. I also, I'm gonna share my screen. I did post a format that we're gonna use on the group. So, but I'm still gonna pose the question. So for everybody to kind of keep in mind, hopefully you all have a copy of it. And I just want everybody to participate. I want to really see how your thinking process and how you formulate your answers. So please feel free to answer. No question or answer is wrong, okay? Let me share this. I do have like two formats, so I don't want to be confused. I think I'm gonna follow the one I have here. So we're gonna start. So I'm gonna pose a question and I want everyone to please participate and answer. No answer is wrong. And I and Dr. Zima will be able to give you feedback, okay? So the first question is, we're gonna start with hypertension. What is hypertension? And I want everybody to be able to speak and tell me what they know about hypertension. What is hypertension? Do I need to call on someone? Go ahead, sorry.
You just wanted us to, I would say, I didn't know if you wanted
Oh, hey.
Sorry, do you want us to type it?
No, I want you to speak because it's interactive. Yeah, you can talk, yeah.
Okay, I was just, hypertension is the force of the blood flowing against the blood vessels through the body.
Thank you, Wendy. You said is the elevated blood pressure, that was what you said? What's your name? Sorry. Erin? Oh, this is
Aaron. Yeah.
oh,
Hi.
hey. Oh, thank you for coming. Thank you so much. Thank you,
I was
Erin.
just, I'm good. How are you?
Yes, thank you. I'm glad to see you. Okay, Mia said high blood pressure. I want other people, everyone to participate, okay? Can you hear me? Oh, it looks like you're muted.
Ada, this is Chiggy.
Yes. Hi.
Hi, you wanting us to define hypertension?
Yes, I want, yeah, a definition of hypertension.
Well, I think it's the condition in which the force of blood flows in the arteries are high, or the elevation of the pressure in the arterial flow of the blood.
Correct. That's good. That's a good definition. Wendy put in the chat elevation in systolic and diastolic BP. That's good. Who else can tell me? I want everybody to be able to participate. Okay, BP over 130. Lakia, thank you, on more than 2 occasions. Thank you, that's very correct. So basically the answer, what I want, what I'm expecting is, oh, sorry, I'm sorry, because I have to admit people. What is blood pressure? Thank you all for all the answers. Blood pressure is when there is an elevation in the systolic blood pressure or diastolic blood pressure. And that's really like just a common knowledge definition. That's really what I'm looking for. The BP over 130 on 2 or more, 130 over 90, I believe is 130 over 80. That's also good. Increased peripheral resistance. Perfect, Anna. That's the patho. That's also part of the pathophysiology. That's also very good. So basically, just a simple definition is elevation in systolic and diastolic blood pressure. It's just that the blood pressure is, the pressure of the blood is elevated, basically. Okay, the next question is, what do you think causes hypertension? I want everyone to be able to participate. Vascular resistance. Wendy, thank you. Thank you so much. Environmental factors, genetic factors, thank you. Perfect, that's very good. Thank you, Anna. Very good.
So
Yes.
may I say, so I was
Yes,
going to say,
yes,
like,
Erin, yes.
actually it's Heidi. I was going to say it's just modifiable, like, so lifestyle choices we could
Yeah.
modify.
Oh, go ahead.
So like maybe the lack of exercise, you know, like they live in a sedentary style. So maybe like an increased amount of sodium in their diet might cause hypertension. I guess I'm just kind of leading down like the diet area, or maybe they don't have the best food choices.
Yes. So those are correct. And thank you. Okay, sorry, I have to. Chronic conditions such as kidney disease. This is Lenora. Thank you. Kidney disease, diabetes, atherosclerosis. Correct. Thank you. Smoking, heart disease, sodium in diet. Karen J. Erin, thank you. Obesity, thank you. Arteries stiffen as we age. Perfect. Renal disease, smoking. hardening of the vessels. Thank you so much. Thank you. I'm trying to see if anybody else is commenting. So I mean, just to kind of summarize everything, major risk factor for hypertension, alcohol abuse, age, race, gender. One, the African American ethnicity, they're more likely to have high blood pressure than everybody else. This is based on just their phenotype and genetics, because of they have higher levels of renin, and that's one of the reasons why. Obesity is one. Having a history of metabolic syndrome, renal insufficiency, EPOH abuse. Somebody mentioned, Kim mentioned alcohol abuse. Thank you. Age, race, gender. Obstructive sleep apnea. And there's also greater incidence in women greater than 60 years of age. And also endocrine disorders can cause hypertension. Okay, thank you for that. The next question is, who are the patient demographics? So what patient would you expect to have risk for hypertension in your clinical setting? Elderly, obese, thank you. Elderly smokers, Wendy, thank you. Lakia, thank you. Oh, wow, I'm sorry. I don't know why it's telling me my internet. Sedentary lifestyle, yes, thank you. Thank you so much. So you would see high stress lifestyle, yes. Yes, correct. We check everyone, so everyone should be screened for hypertension, correct. So basically, women who are older than 60, obese, diabetic patients, patients who have chronic kidney disease. Basically, you're screening everyone. Family history of it, thank you, that's correct. Heidi, thank you. Okay, and that's it. So we've already talked about the demographics. The risk factors are the same thing. Risk factors include diabetes, obesity, lack of exercise, sedentary lifestyle, all the things that we've already mentioned. So the next question is, what do you understand is going on pathophysiologically with hypertension? Thank you. Force of blood against the vessel. Thank you. Thank you, Lakia. I want everyone to be able to, no answer is wrong. Just increase arterial stiffness. Lenora, thank you. Thank you so much. Okay. Okay, so just to recap the pathophysiology, high adults, thank you, Mia. Very good, correct. So I'm just gonna give just a brief synopsis, okay? So one of the main things that happen with pathophysiology in hypertension, there's poor excretion of sodium from the kidney, there's neurohormonal maladaptation, RAS is activated, and there's extra heart sounds. Yes, Erin, thank you, labs. Very good, Erin. Thank you so much on that. So there is a sympathetic involvement. It causes vasoconstriction. RAS causes the release of angiotensin 1 and 2, and that releases aldosterone and causes sodium retention. Also, there's vascular resistance. So what is going on the vascular level? There's decreased arterial compliance because there is the lumen of the vessel is decreased in diameter, right? And that causes peripheral resistance. Also, one other thing that happens on the arterial level is there's endothelial, and I don't know if I'm saying it right, is the lining of the vessels is malfunctioning, endothelial, sorry, I'm gonna write it down, dysfunction. So that also, because that endothelial helps with relaxation and contraction of the vessels. So when that's impaired, and that also increases vascular resistance. Endothelial, I think, endothelial function. Okay. Oh, thank you, Kim. Thank you. Yes. Thank you for that. So that's what's going on pathophysiologically. So you have sodium retention, you have vasoconstriction, you have the RAS system being that's renin and angiotensin aldosterone system. Then you have vascular resistance. So those are the things that happen with hypertension. So can you tell me? Yes, oh, thank you. Okay, so yes, I was actually going to mention that, but I didn't want to go into the, thank you so much. So Dr. Zima just mentioned all the okay, hold on. Renin angiotensin system. Cardiac output of systemic resistance, BP equals cardiac output times systemic vascular resistance. So that's the summation of what the pathophysiologic process is. The reason why I mentioned I'm not focusing on it, but I feel like if you understand the pathophysiology, then you can kind of understand the clinical features. Although, you know, hypertension is considered a silent killer, so is usually asymptomatic. So the next thing we're going to talk about are the clinical features of hypertension. Tell me everything you know about clinical features. I think Erin mentioned some of it already. So tell me everything you know about the clinical features of hypertension. Calbert, I don't know if I'm saying this, sorry. Headaches, blurred vision, tachycardia, yes. Frederica, headache, vision changes, fatigue, edema, chest pain, yes, thank you. Headache, visual changes, blurred vision, papilledema. Kim, thank you. Lenore, Oh, good, perfect. Headaches, vision changes, chest pain, nausea, vomiting, fatigue. That may be arrhythmia. Yeah, that might be like an atypical symptom. Yes, correct. Thank you so much. Oh, I think somebody is trying to join. Yes, thank you. That is correct. So, just to summarize, hypertension is known as a silent killer. It is a symptom. It's usually asymptomatic. So most of the patients that present are not going to have any symptoms. Usually, the only way you know that they have high blood pressure is through the blood pressure measurements. So that's usually one way to know that somebody, but all these symptoms can also be present in people that have high blood pressure. And usually when they're present, the blood pressure is usually high. So thank you so much. That is perfect, the answers you guys gave. So the next question is, how do you diagnose hypertension? Hello. Hey.
Hi.
Oh, mute your thing. Thank you for coming. Yes, exam, past medical history, taking manual BP, good. So, oh, good. 2 readings of high blood pressure, not from the, perfect. 140, 2 different occasions, according to JNC8, under 60, elevated, correct. Lenora, Wendy, thank you. Colbert, thank you. Anna, thank you so much. So basically, before you diagnose someone with high blood pressure, the most important thing you want to do is to get a good history. So we've already talked about, we've covered like the patient demographics, the risk factors. So when you're getting a good history, you're gonna you're gonna ask these important questions. Usually requires multiple visits. Erin, thank you. Recommend reading at home. Thank you. Possible, yes. Thank you so much. Possible ambulatory monitor for more difficult cases. Thank you, Erin. Thank you so much. Yes. Send off labs. Thank you. So basically, you want to get a good history. Then after you get a good history, that will kind of pinpoint you on what's going on. Then you do the blood pressure measurements. You do the physical exam. Usually the physical exam is not going to give you much, but it might give you in some cases, maybe if the blood pressure is really high. So you do a good history, physical exam. And with the physical exam, I guess you're some of the things that you can that will be noted in the exam is probably extra heart sounds. But I mean, if somebody has that, they already have like left ventricular hypertrophy, sorry. Or changes in their eyes. There's retinopathy, but usually they are symptomatic and the exams are usually, is unremarkable basically. So the main thing, I think this is like a board question. You have to make sure that the patient is seated in a comfortable position following a 5-minute rest period, and making sure that they have they didn't have a stressful day and had no stimulants. And the cuff must be placed 2 to 3 2/3 of the arm width. Arm must be supported prior to measurement. BP measurement must be performed in both arms. The arm with higher pressure points should be used for documentation. Then 2 to 3 measurements, 2 minutes apart at 2 separate visits is the gold standard for measurement. And the blood pressure reading should be systolic greater than 130 and diastolic greater than 90 is considered diagnostic for hypertension. Other things that can be done to diagnose include CMP, CBC. So these labs will exclude secondary diagnosis, ambulatory BP, like Erin mentioned. Okay. Okay, so we have Dr. Zima. You know, Dr. Zima is a premier cardiologist, and he wants to take questions from you. So if anybody has any question, you can ask now, okay? Since we're talking about do you have any questions? Do you have any questions on how to diagnose hypertension? Do you need further understanding on, or clinical features, if you want him to just kind of summarize it? We're getting to treatment. We'll talk about the treatment. Oh, I'm sorry. I am so sorry about that. I think my internet is saying that it's going, I don't know why it's doing that. It's going in and out, not sure. I think it's my connection, sorry. Hypertensive urgency. Maybe we can go over that. I'm not sure because I don't know how much time we have. But we can go over that briefly. Okay. Okay, you want to know what's considered a fourth drug for treatment. So now, okay, let's just kind of go quickly because we still got to do heart failure. So I've talked about how you diagnose. You would do a CBC. In some cases, you would do a 24-hour urine methanephrine, urine cortisol. Obviously, you do a urinalysis, renal ultrasound, lipid panel, but the other diagnostics like plasma methanephrin, those are done to rule out endocrinopathies, and you're probably not doing that at initial diagnosis. It would be if the blood pressure becomes resistant, and if the, if they're not stable in treatment, or if it's uncontrolled, then you would be doing that to rule out secondary causes. So we're going to also talk about the blood pressure category. So you know that there are 2 governing bodies for the blood pressure. There's JNC8 and there's AHA. So the most current guideline is the AHA. There are other medical bodies that endorse JNC8 over the AHA because they feel like JNC8 has less bias, but the most current one is AHA, and that's what's in use. So it has, I don't know, I'm gonna share the screen so you guys can kind of see it. I'm gonna share my screen. That's it. Okay. Can you all see the screen? So you can kind of see what's normal is less than 120. Oh, I can't see this. Sorry, gotta push it. What's normal is 120, less than 120 and less than 80. Elevated is 120 to 29 and less than 80. High blood pressure stage 1 is 130 to 139 or 80 to 89. Stage 2 is 140 or higher, or 90 or higher. Hypertensive crisis is higher than 180 and higher than diastolic higher than 120. So I'm just gonna kind of leave this for you guys to kind of, this is the blood pressure category. So basically when you're diagnosing 130 to 139, 80 to 90, that would be a stage 1. So another thing that's important to know in terms of treatment would be this. So AHA recommendation for initiating treatment. So for patients with clinical CVD and systolic blood pressure greater than 130 or diastolic blood pressure greater than 180, you do, hold on one second. Oh, okay. So, sorry. So recommendation for initiating antihypertensive agent. So for patients who have clinical CVD and they have, atherosclerosis or hyperlipidemia, and their systolic is greater than 130 or diastolic greater than 180, they require antihypertensive. For patients without clinical CVD, but their 10-year ASCVD risk is greater than 10%, and systolic BP is greater than 130, or diastolic BP is greater than 80, they also require antihypertensive. So this is the criteria to follow. This will kind of help you to decide, it's very clear cut, decide who needs medication and who needs lifestyle modification and all that. For patients without clinical CVD, if their ASCVD risk is less than 10%, but their systolic blood pressure is greater than 140 and diastolic is greater than 90, they also require medication. Okay. Okay, so I'm just gonna kind of run through this too, so we can get to heart failure. So the first line treatment for hypertension, that is for people who do not meet what I just stated, the treatment criteria, sorry. Would be lifestyle modification. So that includes sodium restriction, DASH diet, exercise, 150 minutes of exercise, weight canceling with BMI reduction. So this is kind of, you can see it just goes into more details as to the BMI. And that's about it. This is just another table that tells you what to do, the specific treatments. When it's elevated, when it's just below 130 over 80, there's lifestyle changes. You reassess in 3 to 6 months. Then stage 1, which is 130 to or 80 to 90, you initiate lifestyle changes. You reassess in 3 to 6 months. And this is just kind of what you do. And the same thing for stage 2. But you also have to remember, per AHA, this is the guideline to follow with starting anybody on antihypertensive. You have to take into consideration the CVD risk. Also, if they're, even if they don't have if their blood pressure is 140 over 90, but their clinical ASCVD risk is less than 10%, they have to be started on antihypertensive. So this is a breakdown of the antihypertensive agents. So you have thiazide diuretic and calcium channel blockers for African Americans. Then you have thiazide diuretics, calcium channel blocker, ACE inhibitors or ARBs for non-Blacks. You also have ACE inhibitors or ARBs for diabetes 2, and chronic kidney disease. Then you have beta blockers for hypertensive patients with MI, SVT, and stable heart failure. Then you have alpha adrenergic blockers for patients with BPH. Hold on, just gotta. So does anybody have question about what I just talked about? Oh, okay, see the question, sorry. So patients with Lenora, patients with white coat hypertension, they have to have ambulatory BP monitoring. That's the way. Dr. Zima, I would want you to kind of chime in on that, but I believe that's how they're diagnosed. Patients who have white coat hypertension at office visits.
Yeah, Ada. White coat hypertension, just for your audience, again, is blood pressure elevated in the office, usually in the presence of the healthcare provider, and yet home blood pressures that are considerably lower. Again, you want to prove, first of all, that the home blood pressure device is an accurate device. So I have the patient bring in their home blood pressure device, and then I have them put it on their arm, the arm that they use at home, in the manner that they do at home. I do this in my presence, but I don't look at their reading. I have them take a reading and put it down on a piece of paper and turn the piece of paper over. And literally within seconds, I put my device on their same arm. A few seconds later, again, they're both in my presence. So that aspect is neutralized, and I take the pressure usually with a mercury sphygmomanometer and my stethoscope. And again, since they're not exactly simultaneous, they're off by some 20 or 30 seconds from one another, I usually will accept things within 5 to 7 millimeters of mercury systolic and within 3 to 5 diastolic as their home blood pressure device being accurate enough for me to use that. If I've ascertained that, then I don't on all occasions proceed to ambulatory blood pressure monitoring because number one, it's not universally available. Number two, it's not universally covered by healthcare insurance. And so I'm usually satisfied with that in a reliable patient who's recorded his or her readings. If AMBP is available, then clearly, that is a gold standard for measuring out of office blood pressures.
Right. Yeah. So yeah, thank you so much for that. So there are other questions. Sorry. So Anna, you are asking when patient is allergic to ACE and calcium channel blockers, what can be second option after diuretic? So if a patient is allergic to ACE, the next step is to put them on ARBs. That's the next step. If they are allergic to calcium channel blockers, per research, they recommend putting them on ARBs, doing a trial of ARBs if they're allergic to calcium channel blockers. But hypersensitivity to calcium channel blockers is very rare, so it's not common. So is this something you've encountered in practice? So basically, if they're allergic to ACE, you try ARBs, and that would be the next step. If they're allergic to calcium channel blockers, you still try ARBs too. The only, I guess the only difference is if they are African American, but I mean, some people can still tolerate ACE. You just have to do a good history, but the evidence-based method is to do ARBs after calcium. ARBs after ACE if they're allergic to ACE. Beta blocker, Coreg could be a good alternative if allergic to, okay. Okay, good. Thank you for that. Beta blocker could be a good alternative. The only thing is the beta blockers they don't have a good, they don't give a good control over blood pressure. So it's only recommended if they, I mean, I guess if somebody, thank you, if somebody is allergic, that would be a good alternative, but it's not a good blood pressure medicine. It does.
Yeah, can I make a comment?
Yeah.
Just want to make sure your audience understands
Right.
what you're saying here, though. Ada's saying if they're allergic to an ACE, an ARB is a good alternative. I think the allergy that she's speaking about, okay, would be rash or much more likely cough. This
Right.
dry,
Cough,
this
yes.
dry cough, which ARBs will not do. Now, on the rare patient that has angioedema from an ACE, an ARB is relatively contraindicated. So please, that's the one allergy where ARB is not the substitute for the ACE.
Okay.
In actuality, the data shows that about 80% of the patients who have angioedema and who are challenged in the right setting, usually a research setting with an ARB, will not have angioedema with the ARB, but that's not for you in your clinical practice.
Okay. Thank you for that. Okay. Are these medications specific to race? Yes. Thiazide diuretic is the first line for African American because based on the studies they've done, that's the most effective. And because African Americans are prone to getting, because of, they're prone to having hypersensitivity to ACE, it's much better to start them with thiazide diuretic. Do you consider age to determine threshold of lowering? With AHA, because that's the most current guideline, there are considerations for age if the patient is greater than 65. So it's like an individualized care. But their guideline is for the 130 over, if it's greater than 130 over 80, that's when you start lifestyle modification. And then you have to then go ahead and measure their screen. You do the ASCVD risk, and based on that, that's how they can be medicated. Sometimes people think they are allergic, but it's a side effect. I know people think, yeah, sorry.
And then this is Chigi. I asked
Uh-huh.
that question. Let me take
Uh-huh.
you back there, and maybe
Okay.
the dog can chime in too.
Okay.
Because if you have your geriatric patients who are running blood pressures in the 130s and 140s, and are you initiating blood pressure therapy for them? And secondly, where are you lowering their blood pressure
Okay.
to, knowing the age?
So in regards to age, there's something that older people have. I think they have isolated, and Dr. Zima, please chime in too. I think, okay, because Chiki is you're in nephrology, so you guys have a way of that's your area of specialty. I forgot to mention that. So I know for primary care, like the elderly, the ones that have isolated systolic hypertension, that's when the systolic is elevated more than the diastolic. Then I think they're started on a hold on, I gotta get my information. They started on a calcium channel blocker. Sorry about that. I think I have to share the screen so I can get it. Sorry. Okay, where did I put it? Sorry about that. Okay. Okay. Sorry, I just have to pull it back up.
You could share it with us later when you find, so that we don't hold up time.
I'm sorry, because I'm trying to, I don't know, something happened to my thing. It won't, I'm trying to minimize it, but it won't move. Okay, it's finally moving. I just want to make sure I'm just hearing the correct information.
Ada, while you're looking for that, I can
Uh-huh.
comment if you want.
Yeah, you can, yeah, go ahead and comment.
In the elderly, in the elderly, even more importantly than in your patients under age 60, try to tailor the therapy to the individual patient. What are the comorbidities that the patient has? Are they frail? Do they fall often? Orthostatic hypotension is extremely common in the frail elderly. They often have wide pulse pressures. So you're treating their isolated systolic hypertension, but be careful, we don't have a single antihypertensive agent that lowers just systolic blood pressure or just diastolic blood pressure. They both go down together, and you do not want the diastolic pressure, even in the standing position, to be under 55 millimeters of mercury, because you will adversely reduce coronary artery perfusion. In that patient, if they have CAD or even occult CAD, you would not want to precipitate myocardial ischemia.
Okay. So I'm just gonna briefly just state that I think we can, I'll just take one more question. I'm gonna go through the chat. I'm sorry. Oh, okay. And then we can move to heart failure. So what I was trying, the reason I want to mention this is because it is a board question. So for MP students who are listening, for systolic hypertension, that's when the systolic BP is greater than 140. Oh my God. Is it possible for you mute your mic, please? Can you mute it? Sorry, please. So it's systolic BP is greater than 140. Diastolic BP is less than 90. And this is common in elderly greater than 60. And also taking into consideration what Dr. Zima said. So if you see this in your exam, the treatment would be low dose thiazide diuretic. Calcium channel blockers, as I stated, is recommended as first line. ACE or ARBs are second line agents, or I guess this is just what it means, adjunctive therapy for ISH, okay? So I just wanted to mention that because it is a board question for the students. What is considered foot drug for treatment after ACE, diuretic, calcium channel blocker, and resistant hypertension? I would think that's spironolactone. Dr. Zima, am I correct? When they have resistant hypertension? Oh, I think you're, oh, you need to unmute your thing, sorry.
Okay, there I am.
Yeah.
I would think that beta blockers might come in before
Before the spironolactone?
before mineralocorticoid
Okay.
inhibitors, yeah. And then of course, mineralocorticoid receptor blockers would be high on my list after that.
The only reason I actually mentioned that because where I've practiced in primary care, the doctor, he goes strictly by the guideline. So that's how I kind of learned what I know. So, but that's good because I wanted you to kind of input that. But for the exams, I believe the answer would be spironolactone. That's what, if it's on the board, on the MP board exams. So, so I think that answers your question, Anna. And then what is the next step in managing a patient with persistent hypertension who is on 3 BP meds already? So, Dr. Zima, please chime in. I think when the patient is resistant, not I think, I mean, the way to do it is to, that's when you do other tests. You do like, you probably, you have to rule out secondary causes. You do an endocrinology profile, lab profile. That's probably when you need to have them get a, maybe you need to get a nephrologist involved. They also need like a renal ultrasound. This is just kind of, there's, you know, this is just kind of just off the top of my head, but Dr. Zima is going to chime in. And Erin, I would like you to chime in too.
Erin, I'll defer to you, ladies before gentlemen.
Oh, okay. So Erin, I want you to chime in because Erin is, her specialty is cardiology too, and Chiggy.
What did you want me to chime in on?
Yeah,
exactly?
managing resistant hypertension in a patient who has 3 BP meds.
As you stated, looking for secondary causes with the renal artery ultrasound labs, that sort of thing, trying to evaluate if there's underlying cause. But there's also the cardiologists that I've worked for. I mean, there's different medications obviously in each class, and some they have preferences for that work better. They feel, have had better effect. So they have preferences that change as far as within a class, like one R they might find works better than the one that they're on, changing from, amlodipine to nifedipine, that sort of thing in the calcium channel blocker class. So there's just more than one way to skin a cat essentially, but yes, looking for secondary cause would be number one.
Okay, thank you.
I'll comment, Ada.
Okay.
Again, the question is not dissimilar to the preceding one. So if it's just resistant hypertension, then again, according to your boards, a mineralocorticoid receptor blocker, spironolactone or eplerenone would be the indication. Now, the question is, when do you pull the trigger on an investigation for secondary hypertension? Again, we're not just looking at a reading on a cuff. We're looking at the whole patient. Are there things that suggest secondary hypertension? Is this occurring in a young individual? Is this occurring in somebody with a familial history of hypertension? Is this occurring in a patient with known multi-system vascular disease in which there's diffuse atherosclerosis and you're suspicious of renal artery stenosis? That type, is there headache and diaphoresis and tachycardia? And are they paroxysmal to lead you to believe there may be a PHEO going on? So again, I pull the trigger on that investigation, which is often costly, time consuming, et cetera, when I've got something that's pushing me towards secondary hypertension. Remember, the secondary hypertension, depending upon who you believe and where the database was taken from, is probably no more than 3% of our hypertensive population. So you're going to be doing a lot of testing if you just willy-nilly pull it. Now, if you confine it to resistant hypertension, yes, it's going to be higher, probably in the 10 to 20% range in that particular group.
Okay. It looks like Erin answered the question. You could max before, says you can max before adding another class. I just wanted to chime in. Another thing that with blood pressure, a lot of people are going to need a 2-drug regimen. So that's something to also have in mind. But this is patient specific, just like Dr. Zima mentioned. You have to, it's gonna be tailored to your patient, comorbidities, and just what your patient is presenting with. But yes, you, just like Erin mentioned, you can max out, and also you, I guess I'm skewed more towards evidence-based, but of course you have to think about the heuristics of how practice goes. But for your exam, it would be, if you're a student, you would have to use 2-drug regimen on most patients. So that's how that works. But for practice, I guess you would maximize, but it's patient specific. Right. Ada, I'm trying to, oh, thank you. So yes, you have to, for the, oh, good, thank you. Yes, I was actually, that was the next thing I was gonna, I'm just gonna briefly go over the caveats so we can move on to heart failure. So we're running out of time, so we're probably gonna spend a few minutes, and then, I mean, for subsequent interactive, then we can go in depth. So,
But just to correct what
Uh-huh.
there's a second I see that because I'm in renal, so I see a little bit more aggression when it comes to managing hypertension and all of that. It is not contraindicated to use ACE or ARB plus spironolactone. There's no contraindication. We do use them.
Okay,
But
good.
you just
Thank you.
have to be mindful. You have to be mindful that you have a high risk of hyperkalemia. So you have to monitor them closely, but you can definitely use MRA, mineralocorticoid antagonists,
Okay.
plus all of that.
Thank you. So I'm gonna just quickly go over the caveats with management, because these are really board specific. So, and also practice specific, but if there's a student, this is gonna be very beneficial because you're likely gonna see this in your board exam. So the first thing is you evaluate for end organ damage, such as hypertensive retinopathy, left ventricular hypertrophy, renal disease, stroke, PAD, MI, and diastolic dysfunction. So you're doing that early on based on your physical exam, your history. So these are caveats with hypertension management. You monitor for hyperlipidemia, hyperuricemia, hyperglycemia, and hyperkalemia with thiazide diuretics. I'm sorry, my pronunciation is bad, but chlorothalidone is preferred because, per evidence, that's what is more potent. Beta blockers mask hyperglycemia, cause bronchospasm, and rebound hypertension. So you got to use it with caution in diabetic and asthmatic patients who have mild or moderate disease, or patients with pulmonary disease. So the best beta blocker is to use ones that are cardioselective, such as metoprolol. Do not discontinue abruptly, is contraindicated in patients with sinus brady and AV heart block. ACE inhibitor causes cough because it increases bradykinin. That's actually a board question. While ARBs mitigates cough, it does cause cough. So adverse effects include angioedema, renal failure, hyperkalemia, teratogenicity, it's teratogenic in pregnancy. It can caution use if the patient has a unilateral. You can use it for someone who has unilateral renal stenosis, but it's contraindicated in someone who has bilateral renal stenosis, pregnancy, moderate to severe renal disease, hereditary angioedema, and if they're taking ARNI, which is sacubitril. Just trying to go through this quickly. Calcium channel blockers causes lower extremity edema, bradycardia, second degree, third degree heart block, and worsens GERD. Avoid use of non-dihydropyridine calcium channel blockers in patients with reduced EF heart failure. For management of stage 2 hypertension, a 2-drug regimen is recommended. For patients with migraine, you use beta blocker or calcium channel blocker. For patients with osteoporosis, you use thiazide diuretic. Alpha blockers cause postural hypertension, so advise patient on first dose syncope. It is indicated in patients with BPH. Aldosterone antagonist is indicated for patients with systolic heart failure. That's advanced heart failure, primary aldosteronism, resistant hypertension, or as an additive therapy to thiazide. ACE or ARBs. It is contraindicated in severe renal impairment, hyperkalemic state. Also keep in mind that NSAIDs, OCP, corticosteroids, SNRI, cocaine, caffeine, appetite suppressants, amphetamine, sympathomimetics cause elevation in blood pressure. So this you would be getting during your history taking when you're asking them what medications they have. So that could kind of clue you in on what may be causing their high blood pressure. Okay, so that's that. Yes, okay, good. Okay. Oh, there's somebody else. Okay, so now we're gonna go to heart failure. What is heart failure? Oh, I'm sorry. I'm supposed to send it to everyone. Okay, thank you, Ada. Oh, yes, Erin, yes. Yes, failure of the heart to pump effectively. Thank you, Erin, for that. I want other people to answer. I kind of want to go through this quickly because we don't have much time. Okay, so, okay, heart failure is when the heart cannot pump enough blood to meet. Correct. Thank you, Ada. Adobe. Okay, if I'm saying it right, I'm trying to say it. Okay, thank you. That's correct. So basically, heart failure is the inability for the heart to inability of the heart to pump effectively. Correct. So also heart failure is considered, it's not considered a disease per se, it's considered a clinical syndrome. So it's like a constellation of features and symptoms that make up heart failure. Dr. Zima, I want you to chime in on why it's called a clinical syndrome, I believe that's what it is. Yeah.
The clinical syndrome, because it's multifactorial.
Right.
And so the diagnosis is made from the history, the physical examination. And then once that diagnosis is made, then you look for the etiology of how you got to heart failure. And Ada Obi's definition is the one that I've used. It's when the heart cannot satisfy the metabolic needs of the body.
Okay.
And there's a whole host of ways to get to that point. But remember, once you've gotten to heart failure, all the compensatory mechanisms that are constantly going on to keep you out of heart failure have already failed.
Okay.
You've tipped the wagon, and now you're in trouble. And then you finally clinically present with the syndrome of heart failure.
Thank you so much. So because of time, we're already out of time. I think I'm gonna just talk about the pathophysiology of heart failure, because this is just one of the many series that you're gonna have. And then Dr. Zima can take some of your questions. So I'm just gonna go over briefly pathophysiology of the heart. So basically, main thing that's happening with the heart is that there is decrease in myocardial function. And this is mediated by, disorders like CAD, MI, and hypertension. So it's more, I guess you can call it an intrinsic pathophysiologic pathway. That's one. There are other things that cause heart failure. Kidney disease can cause heart failure too. So, but basically what leads to the manifestation of symptoms is when there's failure, like Dr. Zima mentioned, compensation. When there's failure of compensation, then that's when you start having symptoms. Then you have the RAS activation, where there's a neurohormonal maladaptation, which results in hemodynamic dysfunction, fluid overload, ventricular remodeling. So ventricular remodeling just means that, the left ventricle, which is pumping the blood because it's working so hard, hypertrophy. So it becomes larger, and the muscle fibers or whatever are stretched. And what happens when the fibers or the musculature is stretched is there's a decrease in calcium synthesis. There's something called the sacroplasmic reticulum, which is critical for calcium ion storage. So that also, because it's impaired, that impairs cellular transport in the myocytes, and therefore, hence, also, adding to the heart not pumping effectively. There's left ventricular dysfunction, there's release of vasodilatory hormones and cytokines, AMP, BMP. I think I mentioned everything. And, there's fibrosis, hypertrophy, and some necrosis. And that happens with, there's some necrosis with when there's, ventricular hypertrophy. So I don't know if anybody has any question with the patho, but I'm going to end with that. Thank you, everyone. So now we can take your questions. If anyone has questions.
I'm here if you have questions.
And Dr. Zima can take your questions too. So ask away. We'll try to answer to the best of our knowledge. I can mention for heart failure that, in order to be able to diagnose, you have to, I'll just pump left side. Right, there's left-sided pump failure, left-sided and right-sided. Just looking at. Oh, what is the indication for furosemide? Furosemide is indicated for symptomatic relief of edema. And Dr. Zima, you can chime in on that.
Yes, certainly. Heart failure can present clinically, this syndrome that we talked about, in one of two different ways, and sometimes a combination of. It can present as low output, which is not that common. So I'm tired, fatigue, a bit short of breath, but low cardiac output symptoms. Or it can present as pulmonary congestion, which is its major presentation.
Right.
I'm short of breath, initially with activity and eventually even at rest. So furosemide loop diuretics in general, furosemide being one of the loop diuretics, is a mainstay of therapy of heart failure,
Yes.
both
thank you.
systolic and diastolic, particularly diastolic, for which we have very little other proven therapy. And it has no randomized clinical trials to support its use, because no one would dare ethically do a randomized trial and withhold a loop diuretic of a patient in heart failure. So you're never going to have such a trial, but clearly it's efficacious and life-saving in the proper situations.
Okay. Thank you so much for that. Lower extremity edema. Yes, thank you. Also with right-sided failure, you have lower extremity edema, abdominal distension, hepatomegaly. For right-sided, you have, acute for pulmonary edema, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. So it's a whole lot with that. And one important thing, like Dr. Zima said, mainstay of both diastolic and systolic heart failure is diuretic. One important thing is, like, you also have to know because you have to have an echo done, and that's how you know what type of heart failure, whether it's reduced ejection fracture or preserved ejection fracture. But the systolic high blood pressure, heart failure. Oh, okay. Now I'm just giving a bit, just to summarize, systolic heart failure is more common than the diastolic. And another thing to note, I believe systolic heart failure is more common in African Americans, although it's one of the causal factors is hypertension. That's just how the phenotype is skewed. But diastolic heart failure is predominantly caused by hypertension, and hopefully Dr. Zima, you can add to that, and other is multifactorial, but one of the main causes is hypertension. And I'm just going to mention two drugs that have mortality benefits for heart failure. ACE inhibitor is one drug, and beta blockers. That the digoxin does not have any mortality benefits, but it helps to decrease hospitalization. Yeah. Okay. So Ada said that. Okay, I think everyone can see what Ada put. So yeah. So
I'll make a comment.
yes.
Remember, your physical findings in right-sided heart failure are what? They're JVD,
Yes.
hepatojugular reflux, HJR, and peripheral edema. Now for a board question. The most common cause of right-sided heart failure is left-sided heart failure.
Yes.
Okay? It's not primary pulmonary hypertension, okay? It's left heart failure with backup of pressures conveyed throughout the pulmonary circuit, causing right heart failure. Sometimes what you see clinically most easily are the right-sided manifestations. But keep in mind that majority of those cases are going to have left heart failure as the cause. Just do an echo or an appropriate chest x-ray and you'll find the left heart failure.
Okay. Thank you so much for that. A lot of my just what I say is just mainly based on skewed more to like just whatever is the available evidence, and then what you would probably see in your board exams. So that's why I said that. But yes, left heart, what you said is correct. That is one of the main causes of for hypertension. When do you use hydralazine? So somebody asks, I believe hydralazine, I know for heart failure is you use it in heart failure for African American patients, like who have, I think, NY class 3, I believe, because that has been found to be efficacious. But what do you think, Dr. Zima, when to use it for? And I believe it's one of those drugs that is additive. I guess you add on as if the
Yeah.
blood pressure is not controlled properly. I mean,
Right, I
Erin,
think-
Erin, you can chime in too. And Chiggy, you
Yeah,
can.
I think hydralazine, with mineralocorticoid receptor
Yeah.
inhibitors, clonidine, it falls, beta blockers, it falls into that wastebasket of drugs that are left over when you've given your big three and you're looking at, resistant hypertension.
Okay. So, yeah. So, I don't know. I think that's what somebody asked.
Yeah, that's correct. You called Chigi. So I was
Yes,
gonna say,
yes,
Dr. Dr. Zima just summarized it.
Yeah.
So after your big three, then you start looking for what is left over. So those are where they fall. I try to, if I can avoid clonidine, I do. It is absolutely the last resort for me, because it's really, very short acting and, causes those highs and falls. And so whatever is left over, that's where I put them.
Dr. Zima, is there anything you would like to add? Oh, okay. Thank you, Erin. Anything you would like to add regarding okay, maybe kind of, I would think maybe elaborate more on when to refer patients to cardiology.
Let me say this.
Okay.
You've covered hypertension and heart failure. You've mentioned, and correctly so, that in hypertension, the physical examination
Mm-hmm.
most often doesn't add anything. Obviously, if you hear a systolic buoy carrying over into diastole in the abdomen, then you're going to be suspicious of renal arterial disease. But in general, you're absolutely right, with the exception of a fundoscopic exam and some other things. In heart failure, it's just the opposite. Now, the physical examination becomes key in making the diagnosis. Unless you're going to get, echocardiograms and chest x-rays and radiate your patients every time they're complaining of shortness of breath, you're going to run up big bills, radiate the patient, and you're not going to have a happy patient when they have to do their co-insurance on these things. So it's your stethoscope, a careful history, listening for those gallop sounds, listening for those pulmonary rales, taking a good history. Is there orthopnea? Is there PND? Is there bendopnea? When the patient bends over, do they get short of breath? Is there bendopnea? Okay, these are the kinds of clues that as a clinician, you need to pick up to make the proper diagnosis of heart failure.
Thank you so much, Dr. Zima. I also wanted you to, this is the final question. When would you involve a cardiologist to just elaborate on that with both hypertension and heart failure care? When would be an appropriate time to get them involved with the patient care? Or when would you refer the patient?
I'm going to be a little critical of my colleagues here. I'm a cardiologist that's board certified in both clinical pharmacology and hypertension by ASH.
Wow.
Most of my cardiology colleagues do not have a very great knowledge of hypertension.
Oh,
I think that's why ASH developed it as a specialty. There's probably just as many nephrologists and internists in that specialty as there are cardiologists. So I would be reluctant to call in a cardiologist to help manage my hypertension. Probably a nephrologist. A nephrologist would be a much better use of your resources. In heart failure, that's a different story. Now in heart failure, that is the cardiologist domain, because besides pharmacotherapy, we have so many other interventions that can be helpful, some of which are mechanical, obviously opening up arteries if there's a burden of ischemia causing the heart failure. If there's renal artery stenosis, we can dilate the appropriate renal artery, etc. But for hypertension, I don't want to say you're on your own, but it's you and the nephrologist in general.
okay. Thank you so much for that. I think that's gonna, I want to mention that Erin did put in the chat box. Yes, when a patient is on multiple medications, especially if there are more than 3 medications, 3 or greater, and they have not achieved their target BP, then yes, you need to refer them to either a nephrologist, I guess, or cardiology.
let's
Well,
let's just say,
nephrology is
let's just say,
cardiology is it. Probably
let's just say,
nephrology.
let's just say a hypertension specialist boarded by ASH. That would be your referral.
Yeah, okay, good. Yes. Oh, I think, Erin, you're muted. You need to unmute yourself. Unmute.
Erin, you're still muted.
You're still muted.
Sorry.
You're
We're
muted.
starting to
You
see
have
more of
say
those.
it.
Can you hear me now?
Yeah, we can hear you.
Okay. We're starting to see more of the hypertension specialty clinics pop up, especially like Nashville area. There, Centennial has one, Vanderbilt has one, but rural areas it gets kind of tricky when you get the patients that are hard to control and you're trying to avoid heart failure. So I think it depends on where you are. If you have those resources, yes, I think hypertensive clinic definitely, it does take up a lot of cardiology time that they could be spending with the more advanced disease and the heart failure patients and the arrhythmias and things like that. So just a caveat of that.
Oh, thank you, Erin. Thank you, Chiggy. Thank you, Erin. Really appreciate you.
Thank you.
Unfortunately, we were not able to cover everything on CHF, but I think we tried. Thank you so much, everyone. So hopefully on our next interactive lecture, we're gonna cover more of CHF. But I want to thank everyone for showing up, for coming. Really appreciate it. And also I want to especially thank Dr. Zima for coming, for taking the time out of his day. Also, please remember Dr. Zima has a book called Modern I'm sorry, hold on, because I have to make sure I have the correct. It's called Modern Healthcare Delivery, Deliverance or Debacle, A Glimpse from Inside Out. I read the book. It is an amazing book. One thing I love about how what he did in the book, he really just deconstructed several concepts, just the healthcare delivery system, what you need to know about it, how the systems intersect with each other. It's a very good comprehensive book. As a matter of fact, I feel like most NP schools actually, or PA schools, they need to adopt it because it's it's a really good book, and just well written. He just has a good grasp of the health system and just ways that we can mitigate the issues that we encounter, and what makes it difficult to run our healthcare system. So,
And if I can, and if I
I'm
could
gonna
chime,
put the yeah, go
and if I
ahead,
could
sir.
chime in, I didn't get to read the book in completion, but I'm an EDPA of 10 years, and I do wish that I had a book like this to
Yes, me too. I wish I had
evaluate and to see before I actually went into practice. So it's a really good book that will help you navigate and kind of clarify some things, especially when
well-written
you
book.
get into the healthcare field.
I'm typing it in the chat box. Hold on, for everyone. Please get it, because one thing I believe in, you want to know as clinicians, you want to have a good, sound knowledge of the healthcare, just like you want to know your patient demographic, you want to know the the treatment guidelines, the patient specifics, or the condition, the disease specifics. You also want to know how the health system is run, how to mitigate the challenges or the complexities in the healthcare system, and how you can tailor it to be able to care for your patient well. So that's what the book does. Sorry, I'm just gonna type it, and I think we are done. Sorry. Modern healthcare delivery, deliverance or debacle. It is on Amazon and Google Books. I bought mine from Amazon.
Amazon, Barnes,
Oh,
Apple,
Barnes and Noble. Sorry, I didn't know.
Apple Play, Google Books,
Okay.
depending upon whether you like to hold a book like I do, or
I
you're
love
a digital
to read
person.
from the inside out. I think that's it. Thank you so much, everyone. Thank you. Thank you, my partners, Rachel and Nana. Thank you for always holding me down, holding our group down. Please, I want to mention we have our YouTube channel, Med Lectures Express. Please, if you have not subscribed to our YouTube channel, please make sure to subscribe. I have, even though I have school and I have to manage my time with school, I'm planning to post a video on color atlas of internal medicine or clinical medicine. It's going to have a lot of images just to help you understand concepts. I also plan on doing like a pharmacopoeia video where you just have, I just take any like a medication, dissect it, so that way it will help you not to look too much. I mean, if you look at your textbook, then it kind of helps you give you a synopsis of what you're reading. So I plan we also have plans to do videos just in granular, simpler form for pathophysiology for students, in-depth video on pharmacology, but I'm going to be doing a lot of video with images, x-rays. A lot of the videos I do are things that I find challenging, that I'm trying to learn, because I'm still learning, and I just do videos in that to kind of deconstruct it and to help me learn. So please subscribe to our YouTube channel, join our group on Facebook, Nurse Practitioners and Physician Associate Resource and Learning Group. And we also have a Facebook business page, Advanced Practice Institute. Please like our business page. And thank you, everyone. I really appreciate you. Thank you so much. And bye. Thank you. Bye, everyone.
Goodbye. Thank you so
Thank
much.
you.
Goodbye.
Thank you. Okay.